Today's webinar is the next part in our Clinical Judgment webinar series, Thinking Like a Clinician, presented by Jeffrey Anderson. I'm going to pass it over now to Jeff. Thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you for having me. So today I wanted to talk a little bit about some of the cognitive science related to information processing and decision making, and then drill that down to how we actually think as EMS clinicians. And we're going to rely heavily on the model that was published by the National Registry that's being used to create the performance items on the new version of the test. So this is part how we do actual clinical decision making, part how to teach clinical decision making, and then how to prepare our students for what they're going to experience. Assuming I could advance my slides. So first of all, I want to talk about how we process information. There's been a lot of research on this related to how we think, how we make decisions, how we teach, how we learn. And one of the models that has come up, that this is not the only model for how we make decisions or how we think, but one of the most popular ones, and one that makes sense to me, is called the information processing model. And so basically what this model describes is how we take something from our environment, a book, a lecture, a patient, whatever it happens to be, and then how we process through and make decisions about it, and then some of the cognitive architecture that's involved. So it starts off with sensory memory. Sensory memory is basically what we get from our senses, and then we pay attention to whatever we're getting from the senses. We pass that on to working memory. Working memory is where we actually process information, how we make decisions, where we make decisions. And then you have long-term memory, which is what most of us think of when we think of memory. And then there's also the environment. So let's talk about the individual pieces. First of all, with sensory memory, as I said, this is the cues that you get from all of your all your senses. So when you smell something, when you see something, when you hear something, read something, whatever it happens to be, your senses give you a cue or a piece of information. And then you can either pay attention to it, pass it on to working memory, or you can just let it go. And sensory memory has a very short life. It doesn't stay there long. Either you're gonna move it on and continue to working memory, or it's going to be gone. And so I say, and like the slide says, it's almost fleeting. It does not last long at all. Then our next step is working memory. So to get from sensory memory to working memory, again, the key thing here is attention. And so for us to be able to do that, to get information from sensory memory to working memory, we have to be able to pay attention and to focus on it. So this is where distraction comes in. And we all know that there's a lot of distractions involved in studying, in class, in our work environment. Our calls tend to be very distracting. There's lots of sensory information that we're having to process through and focus our attention on the things that are relevant. Working memory, also short in duration, but less fleeting than sensory memory. You can keep things in working memory a little bit longer, but not too much longer. One of the other things that's very important for us as educators and as clinicians is that our working memory has a limited capacity. So we can only have so many pieces of information on deck in working memory at one time available for processing. And then if we have too many, that's called cognitive overload. And so we tend to slow down or just stop making decisions, stop thinking altogether. And so it has a limited capacity. Now, there's some debate about what the actual capacity of working memory is, but the consensus is about 4 chunks of information. Now, there's also some variation in what's in those chunks. It could be one isolated fact. It could be a whole collection of knowledge that's organized together. We'll talk more about that in a little bit, but there is a limit. And then the limit is also dependent upon us, our emotion, the circumstances we're in. All of those things can affect the capacity of working memory. But this is the center of process. When we talk about thinking, we talk about making decisions, working memory is where that happens. And so then we go from working memory to long-term memory. So to get something from working memory to long-term memory, as far as learning goes, we would need to rehearse it. We would need to practice it. We would need to concentrate on it. In a clinical setting, concentration is the key. So we were choosing to have a novel piece of information that we need to process, and then we withdraw resources from long-term memory to help us do that. And in the teaching setting, that's very important. If you have a new concept that you want to teach a student, connecting it to information they already have is critical towards making that information stick. And in a clinical setting, we need to draw up information to be able to make decisions about how we're going to treat our patient. So long-term memory is functionally limited in capacity. You know, there's this notion out there that, well, if you want to learn something new, you have to forget something old. That's not true. Now, forgetting can be a very powerful tool in filling your long-term memory, but you don't have to forget stuff to put new stuff in. Long-term memory is used to store information that is then acquired by working memory to solve problems. So the more you know, the faster you'll be able to process a problem, the more quickly your working memory will be able to address that problem. If you have a lot of previous information about that problem, you've seen it before. Sometimes we refer to this as pattern recognition. So the pattern that is in your long-term memory because you've seen a problem before, whether it was in the lab or whether it was a patient you've actually treated, that becomes what's called a schema. A schema is just a collection of information that's connected together by some organizing principle that is then available to you for use. And so if you've seen the same type of patient 5 or 6 times, then it becomes easier for you to handle the patient in front of you because you've seen it before. And that speeds things up. And so long-term memory, that's its function. We want to have as much as possible in long-term memory, and we want to have that information organized in a way that makes it easy to retrieve so that we can apply it to the problem in front of us. An example of this was described by Bordage and Lemo in the academic medicine, where they found that when you had a novices and experts tackling the same problems, the amount of data gathered by experts got progressively lower the more experience they had, but their diagnostic accuracy got better. Sorry for getting all tongue-tied today. So the point here is the more we know and the more experience we have, which helps us gain knowledge. And it's not just like facts, it's also procedural knowledge, how to do things, what to look for. Novices ask a lot more questions, but experts ask better questions because they have a much clearer idea of what's going on. And so our problem as educators, we're not going to make experts in a 15-month paramedic program, but we're going to set them on that path to expertise. And so one of the ways we do that is when we have scenarios in the lab or when we debrief people from the field, we need to get the students to think about, okay, why'd you ask that question? What were you hoping to gather? What information were you hoping to gather from that? How was that going to change what you were going to do? And then I think the model that we're going to talk about in a minute addresses that. But just keep in mind, one of the key things that separates a novice from an expert or anywhere on that path, I'm not sure there's actually like a pure novice or a pure expert, but there's a continuum, is knowledge. It's how much knowledge they have and how it's organized. Schemas. This is an example from the Calgary Black Book. Anybody that's talked to me knows this is one of my favorite things ever. But what the University of Calgary did, this is the medical school, they took a bunch of different presentations and chief complaints, and they created schemas for those chief complaints. So you can see here, this one is for syncope. And what they did was they divided syncope up into smaller chunks that make sense functionally. Now, you don't have to do cardiac versus non-cardiac for every single thing. That works for syncope, doesn't work for other stuff. But the point is there was some thought put in ahead of time. So what they're trying to do at the University of Calgary is they're trying to jumpstart their students' clinical decision-making. Instead of having the student figure out all of these schemas on their own, they're teaching the material to them in a schema. So they can have a conversation about, okay, syncope, what is it? What does it look like? Now let's talk about the causes. And then what information that you gathered from your history and physical points you in which direction in the schema. So it's just an organized way of information stored in the long-term memory that's then available later for solving a problem. So the next time one of those students has a patient with syncope, instead of individual chunks of information coming out of their long-term memory, This whole schema is one chunk of information that can come out. And then now they can work their way through an approach to that patient that's organized and that makes sense. So one of the things that separates an expert from a novice is that the expert schemas are broader, deeper, and more interconnected. Now, this is assuming that the expert is trying to learn and progress and get better every call and every year. We all know some people that don't seem to want to do that, but the ideal is that you're a better paramedic in year one than you are in year zero. You're a better paramedic in year two, three, four, and one of the key functions of that is how you improve your information, how you improve your long-term memory, and how you organize the tools you have to apply to the problems in front of you. So the last piece is the environment, and sometimes in the information processing model, this is not included, but I think it's important because we have had a lot of discussion in our profession about the use of resources outside of our brains. And I want to be very clear about that. I'm 100% in favor of that. I have some resources that I trust that I use. There's others out there. I think, everybody that's working in the field needs to have resources they can refer to. But the question is, how are we using those resources? Now, the environment functionally is unlimited capacity. There's really no limit to that. But the key is we want the environment to augment long-term memory, not replace it. How many of you have been run a simulation in class and you have a student that's just flipping through their flip book and it's pretty obvious that they don't know what's going on and they're looking for help. They're trying to dig their way out versus you have somebody who knows what's going on, but they're not sure about one thing, or they want to verify a drug dose or something like that. That's what we want the resources for. So again, I think resources are great. I think they should be used. But we just need to remember, we need to train the students not to use them as a crutch, but to use them as something to augment what they already have. So one of the things that we really got to understand is that thinking is just hard. It takes a lot of resources for us to focus our attention on a problem and to work our way through is not something we're inclined to do. There's been a lot of different ways to describe this. There's a function in Dr. Kahneman's research that I mentioned down there that talks about the cognitive miser, which basically means your brain will use as little resources as possible to handle the problem. And the reason is because we have these limits in capacity and working memory. And so the brain is trying to protect those capacities so we can continue to think. A lot of Dr. Kahneman's work on system 1 and system 2 is related to the limitations of working memory. He doesn't say that explicitly, and so I maybe am making a bit of a leap there, and please, Dr. Kahneman can correct me if I'm wrong on that, but that's my impression of that. I've spent a lot of time studying system 1 and system 2, and that just strikes me as a lot of what they're trying to get at with that. I definitely encourage you to look into Dr. Kahneman's work. And also, if you're interested in Dr. Kahneman's work, there's a Dr. Patrick Crosscarry who he's a medical physician with emergency medicine, and he's also got a PhD in psychology, and he's studied a lot of this and done a lot of work. So if you Google Pat Crosscarry, you'll get a lot of good information. Some things that get us into trouble when it comes to clinical decision-making, anchoring and confirmation bias. So anchoring is the tendency to fixate on a specific feature of a presentation too early in the process. So you have this cue that you're trying to process, and we'll talk about processing cues in a minute. And for some reason, you've just decided this is the only important thing. And because of that, you miss something else that's very important. And so we got to be careful about anchoring. Confirmation bias, once we've made a decision, we just decide that that's it. It has to be this. It can't be anything else. And that can get us into trouble too. We've always got to have a healthy skepticism about the conclusions we come to so that we can be wrong and we can correct things quickly. We can recognize that we're wrong, and we're going to be wrong sometimes. One of the things that we've got to understand is when you're going about the process of running calls and making decisions and all of this, there's going to be some wrong decisions made. We want those decisions to be small. We want those incorrect decisions to be small and easily corrected. And so if you keep thinking about the process, if you have a healthy skepticism about what's going on and you make sure you don't get confirmation bias, that's going to go a long way to preventing an error that could be very regrettable. Diagnostic momentum. This is a big one for us because diagnostic momentum is all about transfers of care. And so every time a diagnosis or a conclusion is passed from one caregiver to another, it gets stickier and stickier and stickier. It's harder to overcome. And so we need to be very careful about that. For our purposes, as a paramedic in the field, one of the things we need to do is we need to take what first responders or family or whoever else is involved tells us, and we need to not necessarily not trust it, but we do need to be a bit skeptical. We need to make sure that when we come to a conclusion about what's going on, it's based on what we found. And so we've assessed the patient, we've gathered information, and we've compared that information to what we were told. But, a report coming from an EMT to a paramedic may miss some things because the EMT just wasn't looking for certain things. That wasn't part of their training or their education. And so we are adding more to that, more training, more experience. And so we need to take that into account. The same thing when we go to the hospital and report to the nurses and the doctors and whoever else is there, they're taking what we told them and they're also doing their own assessment and coming to their own conclusion. But it's very important that it's their conclusion. If you accept somebody else's conclusion without a little bit of critical thought, you can get in a lot of trouble. One piece of this that's very important is this idea of framing. The way you present the patient to the next person in the chain can make a big difference between, say, them going into triage or going into a trauma bay or another room. And so we need to be clear that, we need to be very careful about how we frame the report to the receiving facility so they get what they need. And if we don't feel like they're understanding us, we would need to try to correct that. But framing is very important because you have a busy emergency department, which they all are these days. They trust us to be able to give them a good report, let them know where the patient needs to go, what resources they're going to need. And so the way we frame that conversation is very important because of diagnostic momentum. Availability just means that things are judged more frequent if they come readily to mind. So if you had a patient that had a certain diagnosis or a certain problem last week, when you have a similar patient present that way, you're going to think about the thing you did last week. It's just common tendency. So the thing of it is, just because you had a certain type of patient last week doesn't mean that everyone that presents after that is going to be the same thing. The odds of being a certain presentation don't change depending on what you've seen in the weeks before or the weeks after. So just keep in mind, common things are common, even if we saw an uncommon thing recently. Emotion is also very important here. When you're angry, when you're scared, when you're anxious, whatever strong emotion you have to deal with, that affects your working memory capacity and it affects your ability to think clearly. And so just keep that in mind. Maybe this is something that you struggle with, that you need to find ways to help with this. One of the things that I've found personally is a box breathing, where you inhale for 4 seconds, hold for 4 seconds, exhale for 4 seconds, hold for 4 seconds, and just repeat. It's amazing to me how calming that can be and how much it frees my brain to be able to focus on the problem again instead of on my anxieties or my anger. And so something to think about, because and this to me, this is important too for educators, because when we raise the stakes so high in an activity, that is bound to create an anxiety in our students. And then we've got to ask ourselves, if they perform poorly, were the stakes too high? Did I do this externally, or were the stakes appropriate for what they were doing? And then if we hadn't worked things so high, maybe they would have performed better. We use this as an example from this very movie. We have some scenarios we call the Kobayashi Maru scenarios that are incredibly difficult, but we make it clear to the students up front that they're low stakes. Nobody's failing when we do those. The point of this is not to fail them and embarrass them. The point is to get them to think, to have some really good conversations. So we run some hard scenarios, and then when we're done, we have a conversation, provide feedback, and that goes a lot better because no one's failing today. They're not. The stakes are low. The whole point of the exercise is to learn. And so by doing that, also, it helps them handle more intense situations. So we are trying to ramp them up to where they can do some pretty difficult calls and it not be a problem, but we're not going to start there. And so it takes a methodical process to get them to that point. So just, don't ignore emotion. It plays a role in how we make decisions and how we process information, and it can derail us if we're not careful. Cognitive forcing strategies are things that you can put in place to help minimize some of these cognitive errors that come up. An example of one that I use is whenever I teach our students that whenever they look at an EKG and they interpret the EKG, they're always going to have some ideas of what they think is going on ahead of time. You can't stop that. That's fine. But one of the things I make them do and explicitly do when we work through scenarios or whatever it happens to be is I need them to tell me specifically, do they think that the rhythm that's on that EKG right now is the problem? Or do they think that something else is causing that rhythm? Because that's going to affect how they treat it. If the problem is something else, if they're in SVT because they got shot and their heart rate's 180 because they're bleeding out, then that's a whole different patient than the person who has a sudden onset of palpitations and near syncope because they went into SVT. So I want them to explicitly tell me, is the rhythm causing the problem or is the problem causing the rhythm? That's just a cognitive forcing strategy that I'm trying to instill in them, because people, especially new learners, they see a rhythm and they want to go full bore all the way down the algorithm, and that may not be appropriate. We see this with AFib. We see this with SVT. There's lots of things. I even saw it with VFib the other day. I was transporting a patient down our lovely Louisiana roads, and leads 2 and lead 3, or lead 2 and lead 1, sorry, we're both in a very nice looking ugly VFib, but then I have a normal pulse ox waveform on channel 3 on my life pack. So pretty sure they're not in VFib, but of course I checked the pulse, talked to the patient. They told me they weren't in VFib. So I was pretty confident we were doing well there. So anyway, that's an example of a cognitive forcing strategy you can have with your students. I found that one be pretty effective. Think about Occam's razor. With all things being equal, the simplest solution tends to be the best one. I know students have a tendency to want to make things exotic and difficult, but they're not always. On the other hand, to balance it out, you have Hickham's dictum. Patients can have as many diseases as they damn well please. So sometimes there is more than one problem going on at this time, and we need to separate them out. And then the last one that's common in medical education, when you hear hoofbeats, think of horses, not zebras. Again, the base reality is common things are common. And so not saying zebras don't exist, but we're more often to see a horse than a zebra. Okay, differential diagnosis, just a little bit about that. This is the process of coming up with lists of possibilities of what can go on. Just one thing about differentials, for normal differentials in like primary care and things like that, the focus is on what's most likely the problem here. And then you come up with a possible list of diagnoses and you gather data to refine the list. In our world, the first thing is what's going to kill them the fastest. And so we operate from a rule out worst case scenario cognitive forcing strategy, where we want to make sure that we're taking care of the immediate problems first, and then we're going to work our way out from there. And so when we talk about differentials, that is kind of how we order the differential. It's not so much what's most likely, but we balance what's likely with also what's going to kill them the fastest. Let's make sure that's not a problem first. So anyway, so let's talk about how this applies to us. So this is the clinical judgment model that has been published from the registry and from a really high power team of authors. If you get a chance to read this article, I'd strongly encourage you to do so. But we're going to focus in today on the circles. So the circle's the same. The model has calls divided to en route, the response, on scene, and then post scene. And so but the circles are the same. So it's basically just, we have these 3 phases of a call, and here's how we process the cues that we get. So a cue basically is any piece of information that requires us to exert judgment. We're having to make a decision about whether it's relevant or not. What does it tell us to do? What does it kind of point us towards doing? And so we're going to talk a little bit about this in context of a call. And this is based on a call that I ran. And so I'm going to work this as a worked example, and it's going to be me now, and it's going to be me at 5 years experience when I first ran the call, which are definitely not the same. So we're dispatched to a 55-year-old male who's having an allergic reaction. That's what we were told. So the first thing I'm thinking about is, well, I was dispatched to an allergic reaction. So who came to the conclusion that there's an allergic reaction? Is this the dispatcher um, following a script? Is this the patient thinking that's what's going on? Is it a family member? That does matter, because we all know that what we get dispatched to is not necessarily what we arrive to find. And working for a service now where I talk to people calling 911 a lot, I have a greater appreciation for dispatchers, because they have to wade through a lot of things to get to where they can give us a dispatch. And so we've got to train our people, our students, to understand that that's the first cue, is what they're dispatched to. And they can't just assume that it's automatically correct. We've got to leave our skepticism intact. So a problem list is basically just the basics of a differential before you actually encounter the patient. So I tell my students that, and I do this myself. I take the dispatch information. I'm listening to the radio as I respond to the call. I'm making a list of problems that could be causing this. So, like, let's say I'm called to a seizure patient. Well, the first thing I'm thinking about, in addition to them possibly having a seizure, is this syncope? Because one of my cognitive forcing strategies is I have those two diagnoses welded together, because you can't tell you the number of times I've gone to a seizure and it was syncope. And because they passed out, they shook for like 2 seconds, and then they wake right up. That's not a seizure. And so not letting diagnostic momentum get the better of me at the very beginning is something I had to learn over time the hard way. So that's your problem list, is just a way for you to kind of focus in on what this could be. What cues do I need to look for? You're priming your decision making for what you're going to see when you get there. So we do our scene survey. And then this is the, looking for information. And then this is the actual model itself, the little circle. So we're going to talk about how this works. So we arrive, we find our patient, Mr. Jim Greer, sitting in a recliner in his living room, and he's unable to talk. So right away, I'm scared. I look at this patient, I see that tongue, and he can't talk. And so my next thought is, can he breathe? Why is he still conscious? How is he sitting in this recliner? There's a lot of thoughts going through my head. So number one, just controlling your fear that I may have to do some very drastic things very quickly when I see this patient. So 5-year paramedic me, that was really a stressful part for me, is I'm trying to figure out, okay, now where's our crite kit at? Do I remember how to use it? All of these things. So let's look at this. We have a man in his 50s with angioedema, tongue sticking out. Does not have any kind of inciting event. So it's not like, he got stung by something or he took a pill or anything. It just happened, as far as you can tell. But you get control of your emotions enough to realize there's no stridor. There's no increased work of breathing. You feel his pulse. His pulse is regular. It's not fast, and it's easily palpable. So these are cues that are very important to figuring out the immediacy of what I need to do for this patient, and it goes a long way to telling me what's actually wrong with them. So I've recognized these are the cues. Next, I want to analyze these cues. So some big questions to me. Number one is, does Mr. Greer have a patent airway? Should have put that one at the top. I didn't do that. But does he have a patent airway? Is he hemodynamically stable? Is there anything that needs to be done immediately? And then is his problem likely to change? Is he going to deteriorate? Is he going to get worse? And so in this case, I assess Mr. Greer, and he can't really talk because his mouth is full. But when I listen to him, he's breathing fine. There's no work of breathing, extra work of breathing. His pulse is good. He's hemodynamically stable. There's no signs of shock. So all I've really got so far is he's got this big tongue that started suddenly, but outside of that, he really doesn't have any other problems, and he's stable. To me, that's the key thing right here. Is if this was some things, it would make him unstable profoundly very quickly. Whereas in this case, he definitely has this obvious problem, but he's hemodynamically stable and he's breathing well. So what does that is what's going on with Mr. Greer leaves the back structures of his airway fine and just causes swelling in the front structures like his lips and his tongue. And so even though he does have an obstruction in his outer airway, the back part, the trachea, the vocal cords, all of that is fine. And so he's able to breathe fine. And that's why he's not freaking out. I'm probably freaking out more than he is. He's able to just interact with me because he's able to breathe well. So that's important. That analysis is very important, because if I determine that he's literally about to crash, and if I don't open his airway in the next 10 seconds, he's going to die, my entire course is fixing to change on this call. So this decision I made when I was analyzing those cues becomes very important. So the next step is to define hypothesis. So your hypothesis is really where your differential kind of comes in. So I see somebody with angioedema, and what are some things that cause angioedema? Anaphylaxis, ACE inhibitor induced angioedema, hereditary angioedema. We have some of that around where I work. Submandibular space infections, Ludwig angio is another way that that's been referred to. They have an infection in their mouth that causes angioedema. And then if they've been receiving TPA, sometimes that causes angioedema. So I have this list of possibilities for the actual problem. And sometimes we don't actually have a list. Sometimes the answer is just they're not dying right now. So my hypothesis is they're not about to die, which is enough. But in this case, I do have some ideas. And so I'm going to say I don't think this is anaphylaxis just because of the way it's presenting. I'm leaning towards ACE inhibitor-induced angioedema, and that's 22-year paramedic self-talking. 5-year paramedic had no idea about any of those other than anaphylaxis. And so I'm sit there wondering, okay, this doesn't feel like anaphylaxis, but I really don't know what it is. But at least I knew enough to see that the person was not about to crash, his airway was not about to collapse, and we had time to sort it out, as opposed to we have to act right now. So and I'll take that. That's good. So generate solutions. Again, what's likely going on with Mr. Greer? This is not a final diagnosis by any means. This is just us trying to organize how we're going to proceed. But my thinking today is this is probably going to be ACE inhibitor-induced angioedema. And we'll go into that more in a minute. Why did I come to that conclusion? Because of what we were just talking about. He doesn't have any other signs of anaphylaxis. He wasn't just getting TPA. Could be hereditary angioedema. I do need to do a little more history about that. But again, my focus right now is I don't need to do anything to manage his airway. Maybe put him on some oxygen, but his SAT is good. And so that's my solution right now, is to not take a particular action to keep assessing further. And that's something that our students have got to understand, is sometimes not acting is an action. We're choosing to not do anything right now because we don't have enough information and there's not a need for us to do something immediately. Next step is take an action. Again, what actions do I need to take right now? I need to assess them further. I need to get a good history. I need to get a med list. But as far as do I need to perform an intervention or administer a medication? I don't think I do right now. Then evaluation. Once we've gone through this, is the call progressing in a way that makes me think my hypothesis was correct, or is there some confounding information that's come up that makes me think I need to reevaluate? There we go. So anyway, now let's repeat. So I've got more information now. I originally decided I don't need to act immediately. I've got some time. And so now I'm going to take a full set of vitals. So my pulse is 86 and regular. Blood pressure is 150 over 90. MAP is 110. Respiration 16 and regular. Work of breathing is normal. SAT's 97. End-tidal CO2 is 42 millimeters mercury with box waveforms. Temp's 98.1. And his glucose is 110. So those would all be cues that I would have to process and decide what to do. And none of them at this point really kind of leads me to take any particular action. What they do is make anaphylaxis less likely. I'm looking through all of these things, and anaphylaxis is just seeming a whole lot less likely to me. Physical exam, pupils are pearl. Skin on his trunk, neck, and arms is normal, so no urticaria. Breath sounds are clear, so no wheezing. I should have added in there was no abdominal signs or symptoms because sometimes when you eat something you're allergic to, your guts get all bubbly and all that, and then that wasn't the case here. So again, every one of those cues I'm processing through this circle. Now, other very important allergies. He has no allergies. So again, what is the likelihood that a 55-year-old man with no history of allergies or anaphylaxis just all of a sudden has profound angioedema like that? Not impossible, but definitely uncommon. Looking at his medicines. So he takes lisinopril, metformin, Levemir, atorvastatin, and aspirin. His past history, history of hypertension, type 2 diabetes, hyperlipidemia, pretty common for a man of his age in the US. Didn't eat anything except for last night, so nothing today, and he woke up with his swollen tongue. So the history of present illness then is he just woke up with angioedema. There was no inciting event. He wasn't stung by something. He hadn't been outside, wasn't taking any new medicines or anything. So looking at this list, the cue that really stands out to me is that he takes lisinopril. And lisinopril is an ACE inhibitor. And so ACE inhibitor-induced angioedema is a known side effect of taking lisinopril. And then understanding how that particular side effect works, which I did not when I first saw this patient, I had to learn about later. You can be on lisinopril for decades and not have any problems, and then just all of a sudden develop angioedema like was presented. That picture in the front was actually from the New England Journal of Medicine from an article about ACE inhibitor-induced angioedema. So if you've seen that picture, it kind of gave the whole thing away. That's the ultimate cue. But anyway, so I've determined this is most likely ACE inhibitor-induced angioedema. If it was going to be hereditary angioedema, they would have a history of hereditary angioedema. And the reason why that one's important to have on the differential is because there's actually medicines to treat that. Now, we don't carry those medicines, but the patient or their family usually has them. And so this is one of those scenarios where the patient has a problem that they have the solution for. They just need us to start the IV and give them the medicine. And some areas I've had that. Usually if you work somewhere that has that situation, they come educate you and let you know what's going on ahead of time, so you're not surprised. He wasn't having a stroke. He hadn't gotten TPA. This wasn't like a stroke transfer. And so the most likely thing here is ACE inhibitor-induced angioedema. And so the reason why that's important is because the treatment for that is supportive. I don't give him epinephrine, don't give him steroids, don't give him Benadryl, because this is not an immune-mediated problem. And so none of the drugs that I would give an immune-mediated hypersensitivity are going to work here. Now, if you're not sure, then obviously treating it as anaphylaxis is appropriate because, again, rule out worst case scenario. But if you're reasonably certain and you're going to monitor your patient carefully, then maybe you can withhold some of those. Again, part of that's going to be up to your medical director and how your protocols are written. But anyway, so that's kind of the conclusion I came to here. So what happened to Mr. Greer? Well, we transported him safely. We didn't do anything to his airway or his give him any medicine. And then he got to the hospital. He ended up sitting around for a couple of days until things calmed down. And then he went home, and he's never taken lisinopril again, hopefully. So that's basically my spiel. I went through things a bit faster than I had intended to, so we've got a bit of extra time. So is there any question or discussion about the clinical decision-making, the clinical judgment model, or anything we've talked about so far? Now it's time to play Stump the Chump. Make me look dumb. Oh, I see from the comments, some of y'all got that. So as y'all are thinking about what you want to say, I'm really glad that the registry published this article, and I'm glad that we're focusing on clinical judgment more. Having studied this for a little while, all the disciplines in healthcare are coming to the same conclusion that we have, that we need to discuss this more. We need to teach it better. We need to teach it more explicitly. I think in every area, physicians, nurses, PAs, nurse practitioners, respiratory, all of us, to a certain extent, we were teaching content And then we were hoping they would figure out how to apply the content on their own or during clinicals. And I think everybody is going more explicit and trying to teach to how to use the material from the very beginning. And I think that's very important. And we're implementing some of this in our EMT classes as well as our advanced EMT and paramedic. And hopefully it will lead to some better results on the registry. But to me, the biggest thing is I want them to be able to skip my first 2 years of figuring things out and start ahead of where I was. That's kind of one of the drivers for me with all of this has been is maybe they don't have to start from zero. They can start from one or two or three, and then they can get better faster. A reference the Calgary Black Book. Yes, it's online. It's free. It's published by I think they're on the 10th edition, if I'm not mistaken now. So just Google Calgary Black Book. It's all there. There's PDFs and there's image files. They embed great into PowerPoint slides. And I tell you the way that I use this most is in my medical class. I teach my medical class, and I'm converting medical to be much more about complaints. I haven't got it there completely. It's kind of tough to do, just to completely abandoning the system by system model. But we're a hybrid program. And so I've left the system by system instruction to the online portion. And then the discussions we have in class are usually based around one of the schemas from the Black Book. Now, to be fair and to be clear about this, this was meant for physicians. So there's some things on there that just aren't relevant to us. But that's part of the discussion. Okay, so you're not going to be able to diagnose that in the field. If somebody tells you they have that particular problem, here's how that would affect what you're doing. But either way, so it's definitely, I think it works well for discussion. My students are kind of sick of the Calgary Black Book now. Actually, they kind of groan when I bring it out. But again, I think it's just a really good way to guide our discussion and to guide feedback. Sometimes we'll run a scenario and then we'll have the discussion, and we use the Black Book as kind of the guide for the discussion. So I think that's important. Just being able to give them good feedback. And then we haven't really talked about this much in this particular lecture, but in the workshop, if you get a chance to go to the workshop, we talk a bit about metacognition. And that's a pretty important thing too. It was just too big of a topic for me to work into this particular one. But metacognition is very important. Thinking about thinking. How are the students thinking about the information they're getting, the scenarios they're running, all of that? And it's very hard to pull that out of them. You really got to work hard to get them out of that. To me, that's one of the best things we can do after a call or after a simulation or whatever it is. Just ask them, what do you think was going on with this patient? And then explain to me how you got there. So I want them to, it's not enough just to say, well, you got the right answer. How did you get the right answer? Explain this to me. One of the things we do to help with metacognition for us, and again, I'm not saying this is right or good, or I'm not telling you to do what Jeff does, because hopefully I'll be able to steal better stuff from y'all than I'm doing now. But one of the things we do when we have oral station practice, we call them verbal scenarios, because I have this real thing about not talking about registry till you take it. But our verbal scenarios, the scratch pad that we give them has a column on the right side that asks for a problem list. And so when they turn over the piece of paper, they read the dispatch information before we start, they have to scratch out a problem list. What's some things that could be going on based just on this? And then at the end, when we're debriefing the scenario and we're talking to them about how they worked their way through it, that's part of what we're talking about. Tell me what was on your problem list. What did you remove? What did you add? Why did you remove and add those things? I think that's very important. That's one of the things my medical director does, is we always come up with a really challenging verbal scenario for them to do towards the end of the program, where he gives the students individually that scenario. And there's always a bit of a diagnostic challenge, and sometimes there's a couple of problems. It just depends. I have 4 or 5 that I cycle around with them. But the point is not whether they get the answer right or not. The point is how they think about it. Tell me, explain to me how you got to the answer you got with. And that's what my medical director wants to know, that he's trying to evaluate their ability to reason through the call. And so anyway, that's one way we try to draw out that metacognition and get them to explicitly tell us, how did you think about this? What were you doing? Because they don't want to do that. I don't know if y'all have experienced that with students, but they don't want to to tell us what they were thinking. And it can be exasperating sometimes. Was there any other questions or, that's a big one. Hold on a second. So I'm reading this comment. I think the thoughts and yeah, that's always a concern, Wayne. It is, and that's the thing that frustrates me about a lot of the discussions we've had this time and the discussions we had before when we switched to the portfolio and the out of hospital scenario is you can't get rid of some of the variability. You can mandate things to a certain point, but then we've just got to unfortunately, we can't make every program do things the exact right way. And that is unfortunate. But I guess the biggest thing to worry about is what we can control and just make sure that our program is not doing what we consider the bare minimum. And one of the things about that whole notion of what the bare minimum is I think people tend to underestimate what the bare minimum is. Their idea of entry level competence, I think, is usually tends to skew lower than entry level competence. And so having, I think a big part of this is just being honest about what you think an entry level paramedic should be able to do right now, and then working your way back when you design your curriculum. But you're definitely, it's a concern. It's definitely a concern. Just, not something we can really do much about as far as individual educators. But I think our state agencies and the registry, they're going to watch out for that, and we'll see. So question, we use Blackboard as our LMS. Unfortunately, we cannot create the test questions similar to the new National Registry style scenario questions of pre-scene, on-scene, and post-scene. Do you have any recommendations on how to implement these concepts into our testing process? This is a big one to me. And unfortunately, we don't use Blackboard anymore. So I can only speak from the lens of Canvas. But Canvas actually has, in the Canvas assessments or Canvas quizzes, there's a thing where you could do it's called a stimulus, where it's basically just a section on the quiz that doesn't have a question in it. It's just a place to put information. We can put an EKG in there. We can put a video in there or a sound file or whatever, and then ask questions related to that particular thing. The old quizzes and the new quizzes has something similar. It's been so long since I used Blackboard, but that's what I would check first, is to see if there is a function in Blackboard. The one LMS has what's called a text only item, where you can just put a bunch of text or image files in there, but it doesn't have a question. But to me, this is what we're doing as a program going forward to help prepare our students for the new registry, is we're creating what's called Canvas patients, what we're calling them anyway, or Canvas scenarios, where we're making our own performance items and then putting them in there for the students to do on their own. But you're absolutely right. That's very LMS specific. Does your LMS allow you to do that? Now, I haven't, this is totally flying by the seat of my pants here, so I may be incorrect on this, but one of the things that we have at our school is also Microsoft Forms. And I've noticed they've really beefed up their quiz function in Microsoft Forms. And so maybe they have the ability to do this in Forms, and you could assign the quiz where it was actually built in Forms as opposed to built into Blackboard. I wish I had a better answer for you, but I don't know Blackboard well enough anymore to be able to speak intelligently on it. Were there any other questions or thoughts? I really appreciate the feedback and the questions. Here's my contact information. Feel free to reach out if you have any questions or want to talk about this. Hopefully I'll learn as much from you as you learn from me.
Oh, Jeff, it looks like there's one more question there from Wayne before
I
we
did
wrap.
see that. Sure. Also, when you talked about memorization, are you talking about them referring back to lectures or, let's say, school protocols per se? I know we have a lot of specific school protocols our students go by, so we can't teach, oh, you can do the skill or give this medication via this route because that's how it's done on the streets. Our school is very protocol driven for our students. There's good and there's bad to that. I think every subject we teach, we can present so much information that it becomes overwhelming. And so maybe having those protocols as a place to start is a good idea, I think. But I don't know, I'd be careful about putting too tight of a ceiling on things because there's a lot of variation service to service. And you don't want to be like on the bleeding edge, but you don't want to be so far behind either. And so I would rather, me personally, and again, I'm not saying y'all are wrong. This is, a lot of this is just preference, but I would rather not have proscriptive protocols for the learning process. But anything they do is subject to us to having a conversation about. So if they do say they want to do something that I think is way out of line, okay, well, why did you want to do that? What, what made you think that that was going to be a good idea? What do you expect to happen if you do that? Those kinds of things. But I think we want to be very careful about not limiting things too much. Uh, and getting them to think about when the protocols don't always apply too is important, because you can't write a protocol for every single situation. And so knowing there's a default, but then knowing there's times to deviate and how that would be appropriate, I think would be pretty important too. That's a good question though. Thanks for that. I know Wayne, by the way, that's why he's pushing me hard.
Well, perfect. If there's no more questions, then I suppose we'll wrap this up here. So everyone, I will be sure to include Jeff's information in the follow-up email tomorrow, as well as the link to obtain your CEU. And if there's any other questions, you can feel free to reach out to me in terms of CEUs. And if there's any questions about the presentation today, you can feel free to reach out to Jeff. So with that, I hope everybody has a fantastic rest of your day and week. And Jeff, thank you so much for being here with us today. I appreciate it. And I will see everybody next time. Thank you. Bye.